Very good afternoon, everyone. Thank you for taking your time out to attend today's CCR. So, from the Department of Gastroenterology, we'll be presenting one interesting patient of a young lady who came to us who was having a pregnancy at that time of presentation. We didn't knew that we'll have the gynecologist also presenting the second part of the CCR today, so we could have involved them. But then what we are trying to highlight today is that once you come to a diagnosis of chronic liver disease or cirrhosis, um, see, most of the time you'll feel that's the end of life for a patient and you don't have much options short of a liver transplantation. So there's a new concept of recompensation coming in where you can, a person who is decompensated, which we are going to show you today, is how this patient behaved and how you can make them better over time. And they can also, a subgroup of patients can lead quite a normal life. And that's what the concept we are trying to introduce to each one of you today. So we're going to have Sarthak, who's our senior resident, who's going to present the case, followed by Dr. Sagnik, who's the assistant professor in the department, who is going to discuss. And in the end, we'll have some questions. Sarthak, please.
Good afternoon, everyone present here. I am Dr. Sarthak and I'll present today's CCR. We are here to discuss a case of a pregnant woman with end-stage liver disease and jaundice. And once we read this line, more often than not, the outlook is generally grim. We understand that this patient is going to be sick. We understand that this patient is going to require some special care. And can we find light at the end of this tunnel is what we are going to discuss. So her story starts from 2021, although she presented to us in 2022. But I want to take you through the timeline. She's a 25-year-old lady who was primary gravida at that time. She was admitted at an elsewhere center with intrauterine fetal death in May 2021 and at third month of gestation. And at that time, she was detected to have some elevated liver enzymes for which she was advised evaluation. And there was no history of any prior liver disease or jaundice. The first reports that were available to us was in our prenatal visits in the December of 2021, where you can see that the liver enzymes are on a higher side. AST and ALT are raised. The bilirubin is normal. The synthetic function of albumin is slightly on the lower side. And otherwise, the evaluation was done with hepatitis B and C virus markers that was negative. Probably because the enzymes were somewhat coming down. I think that's why they did not undergo further evaluation at that center. And she now presented, and she got pregnant as she was largely asymptomatic. And the pregnancy was confirmed in May 2022. Her initial part of gestation was okay, but in March, she developed high-grade fever, which was followed by jaundice. And when she presented to our emergency department, she had complaints of worsening jaundice and altered behavior. Unfortunately, she also had a spontaneous abortion in the emergency. Regarding jaundice, it was present since 1 month. It was associated with passage of dark-colored urine preceded by a prodrome, as I told. It was associated with a mild dull aching pain in the right upper quadrant and not associated with any pruritus, or clay-colored stool. There was a history of increased abdominal distension for 3 days and altered mental status for 2 days. As I told, the relevant past history of liver enzymes abnormalities and pregnancy loss was there, and there was no history of any past surgical history, no blood transfusion, no history of any long-term drug intake or comorbidities or addictions. Here, I would like to diverge a little bit and let's review our evaluation strategy for patients with jaundice. Once a patient with jaundice comes to us, in the mind of the clinician, the most important point is from where is the jaundice arising, whether it's a pre-hepatic, hepatic, or a post-hepatic cause. People label it as parenchymal obstructive or an hemolytic cause. So these are the more common causes of intrahepatic causes of jaundice: viral hepatitis, drug-induced liver injury, alcoholic hepatitis, cirrhosis of any types, and so forth. The obstructive causes can be a malignant or a benign cause. So once we have this, there are certain clinical clues that can help us differentiate between the three forms of jaundice. Now, these are not hard and fast. There is a significant overlap, but just to get our heads running, there are certain clinical points that can help us differentiate. When it is a parenchymal cause, a history of a prodromal illness, a history of a drug intake, history of high risk behavior can help us think about a parenchymal cause coming up, like a viral hepatitis. The patients generally have normal colored stools and dark colored urine. The onset is generally acute to subacute, and a history of liver related event like an ascites, a GI bleed, or encephalopathy points us towards a parenchymal cause. When obstructive cause is there, pruritus is an early and a prominent symptom. Pruritus can happen in viral hepatitis also, but an early and a prominent symptom is a feature of obstructive jaundice. The patient generally complains of a clay-colored stool, dark urine, and it's a generally progressive course. A past history of a biliary surgery also points us towards an obstructive cause, a possibility of an obstructive cause. Hemolytic, generally the symptom is anemia. The patient presents with anemia-related symptoms prominently. It's generally a recurrent course. A patient has normal colored stools and normal to slight urine. So, coming to our patient, what, as I told in the history, the patient had a history of prodrome. Patient had normal colored stools and a dark urine. The onset was largely acute to subacute, and there was a history of possible ascites and encephalopathy based on the history. Then, when we, in this patient specifically, we have to see whether this jaundice is related or unrelated to the pregnancy. Now, pregnancy brings its own set of diseases that generally pop up in the later half of pregnancy, like intrahepatic cholestasis, acute fatty liver, or HELP syndrome. Now, these are related to the pregnancy. How we differentiate based on our clinical clues is largely based on the time frame when they turn up. If the patient is presenting in later in the course of gestation, these diseases needs to be evaluated. However, early in the course, they can come, but they would be lower down. If we have a definite evidence of a liver test abnormalities prior to this pregnancy, it's a hard evidence that likely there was some liver injury ongoing before this pregnancy. And they, especially these three, generally improve after delivery, which is not the case when it's unrelated to the delivery. And there was a history of prodromal illness, as I told, high risk behavior or history of blood transfusion can point us that this, whatever jaundice this is, it's unrelated to the pregnancy. Coming to our patient, it was seen in early part, very early part. In fact, it was the liver function abnormalities were there prior in the prenatal visits, and likely it did not, as you will see, it did not improve with the delivery. So we had the initial investigations available to us. It was the last prenatal, compared to the last prenatal investigations, there was a sharp jump here in the liver enzymes. It rose to thousands, and the bilirubin also rose. And you can see that the synthetic functions have started to come down here. So there was some injury that happened at this time. And when she presented to us, although the liver enzymes were on a settling trend, but the synthetic functions were going down. The bilirubin was raised to 13.2 and the albumin was 2.9. Sitting in emergency, other investigations available to us is generally an ultrasound. Ultrasound here revealed the possibility of a liver parenchymal disease with gross ascites, and that ascites revealed a high SAG low protein ascites, likely suggestive that this ascites is because of portal hypertension. Ammonia was raised, and there was evidence of coagulopathy. So all this suggests likely that the disease is likely a chronic liver disease, now presenting with its decompensation following an acute insult. So on examination, there was deep icterus, there was grade 3 ascites and bipedal edema. She was shifted to ICU, and all the supportive care in form of albumin, anti-encephalopathy measures, antibiotics were started. And a plan was made that if she proceeds with further deterioration, we can plan a plasma exchange. Here, the possible differentials were kept. The first and foremost had to be kept to be sepsis. Then acute and chronic liver failure, possibly precipitated by viral hepatitis or an HVOTO, needs to be evaluated here. A rheumatological illness like lupus or adult onset still disease could present in this way in a patient, in a similar way in this patient. And possible a tropical infection has to be ruled out in our setting of illness like malaria or leptospira. So the diagnostic worker, since we had narrowed down our clinical history to a hepatocellular cause, the viral panel came out to be positive with IgM HEV turning out to be positive. The autoimmune panel revealed ANA to be 3 positive, and the immunoglobulins were almost twice the upper limit of normal. Other workup was negative. The entire sepsis screen repeated a couple of times was negative. So the syndromic diagnosis here we kept was acute on chronic liver failure, grade 3, with the acute component like early HAV infection, which itself has a high maternal mortality of 15 to 25% even in a non-cirrhotic patient. And the decompensated chronic liver disease, possibly IIH cirrhosis with ascites. The organ failures were hepatic coagulopathy and encephalopathy. And this diagnosis, once we made this diagnosis of ACLF grade 3A, it has a very high mortality of 70 to 80%. Now, why do we have to make this diagnosis? Why do we have to recognize this entity early and treat the patient aggressively? It's because based on a systematic review from our center, we had compared the there are different definitions of ACLF present across the globe, and the most common being a PASL, EASL, and AXIL. In these definitions, one word resonates unanimously. It's the word of mortality. So this disease entity itself has a very high mortality, upwards of 40%, based on the definitions you use. So that's why understanding this disease and recognizing it early was so crucial in her management. When you see the landscape of ACLF across the globe, you will realize that the most common acute precipitant and acute chronic liver disease was in the most common acute precipitant in our Southeast Asia part was definitely alcohol. But viral hepatitis, as we were suspecting in this case, acute accounts for about 13.8% of the acute precipitants. Coming to the underlying cause, when we see of why the patient with ACLF, what was the underlying cause in this underlying cause of cirrhosis in these patients, you'll see that most common cause remains alcohol. And what we were suspecting in this patient was AIH, possibly that was 3.2%. So it's a varied manifestation of a disease. And this disease has a definite acute factor and a chronic underlying disease with the landscape shown here. Following on her follow-up in our department, the bilirubin continued to rise. And despite our critical care management, there was a slight improvement, but the bilirubin and synthetic functions here being supported, the albumin being supported, was still on a very lower side. So synthetic functions were going down, bilirubin was going high, and the patient had a slight transient improvement in clinical status. So here we decided that the patient should undergo transjugular liver biopsy. And to discuss it, I would like to invite Dr. Jasmine.
Good afternoon, everyone. We'll be discussing the liver biopsy of the patient. Here we can see the lower power of the biopsy. We have a multiple cores, fragmented cores of the liver biopsy, showing a disarrayed architecture, that the normal architecture of the liver biopsy is not maintained. And we can see there is some incomplete nodule formation is there, separated by the thin fibrous septae, which is one of the first signs of the chronic hepatitis. Here, this is the higher power of the biopsy. Here we can see the portal tract, which is densely infiltrated by the dense inflammatory infiltrates comprising of lymphocytes, plasma cells, eosinophils, and occasionally some polymorphs. And inflammatory infiltrates is going into from away from the limiting plates into the hepatocytes, which is causing the interface hepatitis. So we already saw in the lower power there is a slight hint of a fibrosis, and here we can see there is the interface hepatitis. So the chronic hepatitis features of a chronic hepatitis is confirmed. Here we can see the portal tract is very much expanded. Another portal tract which is lying very close to each other, which we don't see normal in a normal biopsy. So there's a bit of a fibrosis going on. And here we can see some ballooning degenerations of the adjacent hepatocytes. Here we can see some ductules, regenerative ductules. We don't, in this biopsy, we didn't see a normal bile duct actually. This was all the regenerative ductules, regenerative bile ducts we see, which is infiltrated by, again, many inflammatory infiltrates comprising of the lymphocytes, plasma cells, and eosinophils. Here we can see some pseudo SNR formation of the hepatocytes. Again, a foci of inflammatory infiltrates. Some plasma cell, this is a higher focus of the biopsy to show you the plasma cell clustering better. Here we can see some cholestasis going on. This is ductular cholestasis happening. And in the next slides also, we can see some canalicular cholestasis happening along with the intracytoplasmic cholestasis. which happens in the case of cholangitis. And cholestasis is not a feature of just a autoimmune hepatitis. Another focus of a higher focus to show the plasma cell clustering. So in the end, with the overall histomorphological features, we concluded it was overlap syndrome of autoimmune hepatitis with autoimmune cholangitis. And we have staged it accordingly to the modified Ishar grading, A4, B2, C4, D4, and stages 5 by 6, which conclude to the incomplete cirrhosis.
Thank you, Dr. Jasmine. And once we received that biopsy, during this course, the patient already had developed an hospital-acquired lower respiratory tract infection, and she was being managed with antibiotics and other supportive there. Based on this biopsy, we took a call. Since the hepatic functions were worsening and knowing well that the patient already has an infection, we still, after a complete discussion with the patient, we took a decision to start her on steroids to take care of the underlying etiology. And following which, you will see that the LFTs improved. Here is where we started the steroids, and the LFTs, the bilirubin started to settle, the albumin was rising, coagulopathy improved, and the patient clinical status also improved. And she was discharged here on diuretics and anti-encephalopathy measures, and she was advised against conception because of poor hepatic functions. The patient continued to follow in OPD. The ascites resolved by September 22. LSM had the liver fibrosis has improved from 19.6 to 10. There was no recurrence of encephalopathy or ascites, and the therapy was continued till December 22. This therapy of diuretics and anti-encephalopathy was stopped in December 22 because there was no recurrence, and patient showed significant improvement. So this is the timeline of the patient. Here she started with the first pregnancy loss, then there was second conception, then here happened the hit of ACLF, and here we started the therapy. The LFT had normalized by November 22, and the diuretics and anti-encephalopathy measures stopped in December 22. And here is what somewhere we call that the patient was recompensated, which we'll discuss. This is how the trend of liver enzymes look like. This is what there was the hit of viral hepatitis, and then it has gradually improved. The IgG trend has now the patient had normalized and was doing well. Albumin had improved. The liver fibrosis had now it's somewhere in the range of 4.5 to 6. So that's that's how recompensation looks like in real life. The patient is doing well. Patient delivered she carried her third pregnancy to its full term, and that's how it looks like now. So, what are the outcomes of pregnancy in cirrhosis? It's generally driven by the severity of liver disease. The cirrhosis has its own risk of increasing preterm delivery, low birth weight in the child, C-sections, postpartum hemorrhage turning up. But it's very strongly driven by the underlying severity of the liver. Predictors could be presence of portal hypertension, untreated varices. ALB score has been shown to be relevant in predicting the outcomes. And prior history of hepatic decompensation is one very important parameter that predicts the outcomes. So the lessons learned from this case, the first and foremost is timely recognition and diagnosis of this clinical entity of ACLF, a comprehensive management and to stabilize the organs. The pregnancy outcomes improve after improving the underlying liver disease. If we can optimize the patient, even the AACLD guidelines recommend the same. We have to optimize the patient prior to the conception. And ACLF is not the end of the line. The etiological control improves survival and may lead to recompensation. Now, to discuss recompensation, I would like to invite Dr. Sarknek on the stage.
Thank you, Sarthak. So we've discussed a very interesting case where we had a patient with cirrhosis who went to ACLF and we were able to bring her back again. The term cirrhosis is usually associated with poor outcomes. Both patients and physicians are worried when you have someone who comes up with this diagnosis. And over the years, what we've come to understand about the natural history of this disease is that decompensation, this term we've been talking about, carries a very important connotation in patient outcome. And a decompensation basically means either the development of ascites, variceal bleed, encephalopathy, or development of bacterial infection, or SBP. And this is like a watershed moment over here. You can see that the mortality goes straight from 10 to 15 years all the way down to 3 to 5, even with the best possible care which is available to us right now. And once a decompensation happens, The patient remains at a risk of further decompensations, ACLF representing a very severe form of that, as well as the risk of hepatocellular carcinoma. However, further understanding of cirrhosis has given us knowledge that it is the etiological factor eventually which drives the necrosis and inflammation in cirrhosis and eventually leads to complications which lead to the development of portal hypertension. And further disease occurs because of two reasons. One is complications associated with portal pressures itself, and the second is the complications associated with the cirrhotic process. And if you're actually trying to treat these patients in a holistic manner, etiological treatment has to be at the forefront of this management, because that is what eventually manages most of your downstream events. If we target the management of only portal hypertension or other oxidative mechanisms, we are only selectively targeting the end-stream events, and we cannot bring it to fruition. This slide just highlights how change, even one stage of cirrhosis can impact your mortality. So you have a compensated patient here, the mortality is somewhere around 3.4%. And as soon as the patient decompensated, it jumps to 20, with another decompensation maybe as high as 57. And as we saw in our patient, she was very sick on admission and even developed an infection. So over time, we have developed this concept of recompensation. This was already known clinically, that if you are able to manage the etiology of a patient effectively and the complications, it gives the liver the time to recover and regain some of the hepatic reserves which is lost. And this was officially formalized in 2022 by the Bavino Consensus, who said that if you're able to control the etiology, that is cure or control the primary, and you can keep the patients off medication for 12 months without any further decompensation. So the patient would not be on diuretics and still not have ascites. Patient would not have variceal bleeds of beta blockers or encephalopathy of rifaximin. And the patient's liver function remains normal. You would have achieved what is known as recompensation. So this is a fairly new concept. And there are very limited studies, large-scale studies on this. The first one was this one on hepatitis B virus. It's from China, because that's where the burden of the disease is maximum. This group was able to show a very impressive 56.2% patients being able to achieve recompensation of therapy with effective control. And what is even more interesting is that you see the Childs and MELD scores, which traditionally reflect severity of liver disease. They continue to remain well even at, say, 120 weeks after control of etiology, much better than those in whom this control could not be achieved. And this improvement does actually translate into better survival. This was a subsequent study from Hong Kong involving almost 4,700 patients with Hep B. And it showed that this green line is patients who have compensated disease, so a survival of 10 to 15 years, as I've shown. And this line represents those who have recompensated. And you can see over time that the survival difference is not more. But if you compare with those who continue to be decompensated, it presents a very bleak picture for those who we could not recompensate. Similar story for alcohol, although the recompensation rate here you can see is much lower. This is probably because the tools which we have to assess alcohol use disorder is poor, it's mainly subjective. There is a lot of work going on in that. However, even with the limited numbers, they were able to recompensate around 18% with alcohol. There was a significant difference in liver-related events as well as all-cause mortality. So definitely, liver recompensation has to be the target of our therapy. The data on hepatitis C comes from India. This was the Punjab model, which has been cited widely. It has shown that there's improvement in both all-cause mortality, and very impressively, a significant drop. The liver mortality is, I don't know, close to zero in this picture. So that just tells you what great things we can achieve, even at an advanced stage of cirrhosis, if we are able to control etiology. Autoimmune liver disease, however, has always been a different ballgame, because there's been a concept that once decompensated, steroid use can lead to a high amount of infections in these patients. So people have differed on opinions whether they should be treated or not. This was the first study which showed that if we treat patients who have decompensations and AIH with immunosuppressive therapy with steroids, patients do recompensate. And you can see the rates here are more than 30%. And patients who had lower ALT and IgG at presentation along with higher counts had higher recompensation. You can see here, of the total number of patients, almost 1/3 of each group and 1/3 of patients of child C recompensating is a very impressive number, because these patients are usually people who are listed on the transplant group. Similarly, you can see here that the survival after recompensation was quite similar to those after compensation. Does timing of therapy affect recompensation, and when should we start? So just as we showed in our case, early initiation of immunosuppressive therapy after index decompensation was associated with better survival rather than delaying it. So what is our experience in autoimmune hepatitis? We have an over 10-year follow-up and more than 500 patients of AIH treated in our liver clinic. The disease is not very well recognized in India, so most of our patients being a tertiary care center refer with advanced liver disease or cirrhosis. But from our patients, we were able to identify 112 patients of AIS-related decompensated cirrhosis who we did give steroids and were able to have a long-term follow-up. Almost 53% of our patients recompensated and were taken off therapy. And what was even more impressive is that following up these patients for a long duration, 85% patients remain well. So basically, what we are trying to convey is if your patient has AIH and recompensates, they are more likely to remain well than deteriorate. There was a significant difference in the overall survival between these patients as well. And very few patients actually went on to have the redevelopment of ascites or a bleed or encephalopathy. And we found that if you target young patients with a good child-pugh score and whose enzymes normalize in 6 months, you're probably dealing with somebody who's going to get better on steroids. Similarly, we found that patients who had child and MELD, which were in the earlier stages, I'm sorry, can we just go the child and MELD, which were in the earlier stages of disease, did better. There are still controversies regarding what is the dose of steroids we should give this patient. This study from our clinic showed that both low and high dose prednisolone were similar in achieving response in AIH cirrhosis. We have also tried alternative agents like tofacitinib with a good response. This remains an area of ongoing research. So in summary, patients with autoimmune hepatitis can be recompensated. Cirrhosis or ACLF are not an endpoint for them. And early identification of immunosuppressants after identifying the etiology is the way to go. Once the recompensation is achieved, they have a good quality of life and their long-term outcomes become similar to those who have compensated disease. Thank you so much. I would just like to inform that we are celebrating our Foundation Day on the 14th of February, and we would love it if everybody joins us as well. Thank you.
Okay, thank you, Sarthak. Thank you, Dasreen, and thank you, Sagnik. So the reason why we wanted to present this case as an example for recompensation was this young lady had 2 fetal losses, and then once she was treated, her decompensation from a decompensated state, she became recompensated and she was able to conceive well. So this is a classic example where cirrhosis, which I'm sure most of our crowd over here from our gynecology department, you always fear. When you have these patients getting pregnant, you have lots of fear what's going to happen in terms of one, their fertility and the complications which these patients develop over time. So I'd like to now open for any comments, questions from the audience, please. No. So for that part, the etiology control is important. So etiology always control continues. So drug for hepatitis B would continue. Hepatitis C, you got a finite treatment. Alcohol, the patient is off. Autoimmune steroids will continue, but what's coming off is the use of diuretics. Like in this patient, diuretics were used for controlling the ascites. 2 is the use of anti-HE medications in terms of lactulose or rifaximin. They come off, the patient is defined as recompensated. But you will still continue immunosuppression. That has to continue for life. You cannot stop immunosuppression in these patients just to document and label these patients as recompensated. You stop immunosuppression, so you're going to be back to a decompensated state. No, it's biopsy proven. The pathologist gave us a diagnosis. We always depend upon on the pathology colleagues to give us a final stamp for a patient on the liver biopsy that this is autoimmune hepatitis. This is nothing else. Yes, case to case basis we do take, but then we'll always prefer doing a liver biopsy to confirm, or it's not really a confirmation, but you're ruling out other possible causes of cirrhosis or chronic hepatitis in a particular patient. Yes, correct. But I think the important reason why we subjected the patient was for the liver biopsy was reports were still elevated. So And plus, she had elevated transaminitis in both her previous pregnancies, which was unexplainable with the hepatitis E virus in the current pregnancy. So that gave us an idea, possibly something else going on, which is leading to her recurrent pregnancy losses, though workup for other APLA and other things were negative. No, so she had a problem starting to begin with 2021. Neither she had a hepatitis E infection at that time, nor the pregnancy to begin with, or maybe associated pregnancy. But then autoimmune, we really don't know triggers. This was just an autoimmunity to autoantigens. We really don't know what causes this disease. Only what you know is if you give immunosuppression, they become better. But that, what is the reason? There are multiple autoimmune markers which come positive. People have possibly raised what kind of say antigens these are, but we don't really know the cause, exact cause. But this is very interesting concept which is coming up where a decompensated patient can be made recompensated and he can have a good outcome. That's a select group of patient as highlighted by Dr. Sagnik in his review. Okay, if there are no more questions, I'll like to thank everyone and invite the gynae department to take over.